In this video we will discuss about microbiology and pathogenesis of aspiration pneumonia, risk factors of aspiration pneumonia, clinical feature and diagnosis, and finally, the treatment of aspiration pneumonia. As an introduction, let us see what aspiration pneumonia is. Aspiration pneumonia is an infection caused by specific microorganisms. Aspiration of small amounts of oropharyngeal secretions is normal in healthy persons during sleep, yet microaspiration is also the major pathogenetic mechanism of most pneumonias. Large volume aspiration, which is also called macroaspiration, of colonized oropharyngeal or upper gastrointestinal contents is essential for an aspiration pneumonia to occur, and it is a part of a continuum that also includes community and hospital-acquired pneumonias. Aspiration pneumonia accounts for 5 to 15% of cases of community-acquired pneumonia. Risk factors of aspiration pneumonia. Aspiration is often the result of impaired swallowing, which allows oral or gastric contents, or both, to enter the lung, especially in patients who also have an ineffective cough reflex. Large volume aspiration occurs with dysphagia, head, neck, and esophageal cancer, esophageal stricture and motility disorders, chronic obstructive pulmonary disease, and seizures. In addition, degenerative neurologic diseases, multiple sclerosis, Parkinsonism, and dementia, and impaired consciousness, particularly as a result of stroke and intracerebral hemorrhage, which can also impair cough clearance. The frequency of stroke-associated pneumonia is related to the severity of neurologic illness and its associated immune impairment, with higher rates among patients requiring intensive care than among those admitted to a stroke unit. Impaired consciousness can also result from drug overdose and medications, including narcotic agents, general anesthetic agents, certain antidepressant agents, and alcohol. After adjustment for other risk factors, antipsychotic medications increased the risk of aspiration pneumonia by a factor of 1.5 in a study involving hospitalized patients. Enteral feeding can lead to high-volume aspiration, especially when associated with gastric dysmotility, poor cough, and altered mental status. Some studies showed that the incidence of early-onset pneumonia decreased among patients receiving systemic antibiotics at the time of cardiac arrest. 2 intervention studies involving comatose patients showed a benefit of administering prophylactic antibiotics for up to 24 hours after emergency intubation. The microbiology and pathogenesis of aspiration pneumonia. Lungs are not sterile, there are diverse communities of microbiota in the lungs. The stability of the lung microbiome is probably maintained by a balance of immigration and elimination of bacteria, and by feedback loops. Immigration involves bacterial movement from the oropharynx to the lung primarily by means of microaspiration, and elimination mainly occurs through ciliary clearance and coughing. An inflammatory event may lead to epithelial and endothelial injury, creating a feedback loop that can promote inflammation, disrupt bacterial homeostasis, and increase susceptibility to infection. This may result in a rapid shift from a diverse microbial mixture to dominance by a single species, for example, Streptococcus pneumoniae or Pseudomonas aeruginosa. A macroaspiration event, particularly in a patient with risk factors for impaired bacterial elimination, such as reduced consciousness or an impaired cough reflex, could then overwhelm the elimination side of the immigration-elimination balance, further disrupting bacterial homeostasis and triggering an increase in a positive feedback loop leading to acute infection. Recent studies have shown that the predominant pathogens in aspiration pneumonia are bacteria that are usually associated with community and hospital-acquired pneumonias, and anaerobes are recovered less frequently. Clinical features. Many episodes of macroaspiration are unwitnessed, therefore, the magnitude of the exposure is often unknown. Clinical features range from no symptoms to severe distress with respiratory failure, and the clinical consequences may develop acutely, subacutely, or slowly and progressively. Aspiration into the lung can affect either the airway, causing bronchospasm, asthma, and chronic cough, or the lung parenchyma. Aspiration pneumonia is usually acute, with symptoms developing within hours to a few days after a sentinel event, although anaerobic aspiration may be subacute because of the less virulent bacteria, and clinical features are difficult to distinguish from those of other bacterial pneumonias. Aspiration pneumonia is associated with higher mortality than other forms of pneumonia acquired in the community. Chemical pneumonitis is characterized by a sudden onset of dyspnea, hypoxemia, tachycardia, and diffuse wheezes or crackles on examination. An aspirated solid foreign body can obstruct the airway and lead to post-obstructive pneumonia, further complicating the distinction from bacterial pneumonia. Diagnosis. The diagnosis of aspiration pneumonia depends on a characteristic clinical history, witnessed macroaspiration, risk factors, and compatible findings on chest radiography. These radiographic findings include infiltrates in gravity-dependent lung segments, superior lower lobe or posterior upper lobe segments, if the patient is in a supine position during the event, or basal segments of the lower lobe, if the patient is upright during the event. However, a chest radiograph may be negative early in the course of aspiration pneumonia. One of the entities that can be confused with aspiration pneumonia is negative pressure pulmonary edema. It is important to consider this diagnosis, which is accompanied by bilateral and generally symmetric lung infiltrates and is the result of breathing against a closed airway, after general anesthesia, choking, or near drowning, all conditions that may also be accompanied by aspiration. Treatment. Antibiotic selection depends on the site of acquisition, the community, a hospital, or a long-term care facility, and risk factors for infection with multi-drug-resistant pathogens. Risk factors include treatment with broad-spectrum antibiotics in the past 90 days and hospitalization for at least 5 days. For most patients with community-acquired cases, treatment with ampicillin isulbactam, a carbapenem, ertapenem, or a fluoroquinolone, levofloxacin or moxifloxacin, is effective. In such patients, we suggest adding clindamycin to another drug only when the risk of predominantly anaerobic infection is high, as it is for patients with severe periodontal disease and necrotizing pneumonia or lung abscess. With mixed infection, elimination of aerobic pathogens usually alters the local redox potential, eliminating anaerobes. For hospital-acquired cases with a low risk of multi-drug-resistant pathogens, a similar regimen may be used. If resistance is a concern, broader-spectrum treatment with piperacillin, tazobactam, cefepime, levofloxacin, imipenem, or meropenem, either singly or in combination, is required. In cases of multi-drug-resistant infection, an aminoglycoside or colistin may be used as part of a combination regimen, with the addition of vancomycin or linezolid if the patient has documented nasal or respiratory colonization with methicillin-resistant S. aureus samples. The investigators suggested that routine antibiotic treatment should be started only if bacterial infection is suspected, but may be discontinued if bronchoscopic cultures are negative. On the basis of data from studies of community-acquired pneumonia and hospital-acquired or ventilator-associated pneumonia, we suggest 5 to 7 days of treatment for patients with a good clinical response and no evidence of extrapulmonary infection, and longer treatment for those with necrotizing pneumonia, lung abscess, or empyema. The choice of therapy should consider potential drug-related adverse events, including Clostridium difficile colitis and selection of antibiotic resistance. More data are needed to identify the best antibiotic regimens for aspiration pneumonia and to determine the duration of treatment. No randomized, controlled trials have shown a role for glucocorticoids in the routine treatment of aspiration pneumonia.